Good morning, everybody, and welcome to Osteology Barcelona 2019. I'm Luca Gobbato. I'm here with Martina Stefanini, our good periodontist from Bologna, and from Brazil, Cleverson. And then we have Dr. Jay from Seoul University, and of course, Hector from Michigan University. So welcome, everybody. What we are going to do is to show some cases and see how our background are and what are our decision-making in the treatment. For example, of this first guy, who is a 30-year-old male who has basically no condition, no disease, no allergies or medical condition, and no contraindication to treatment. He's pretty much a healthy guy. The only problem he had is that he which is not a problem, of course. He likes to play basketball, and unfortunately, he had an accident during the last match. And he has been sore for a couple of weeks. He thought the pain could probably go away by himself, but that suddenly the central incisors start to become mobile. And we see he doesn't have any type of periodontal disease. We check for the full mouth X-ray, and we see in the upper left central incisor there is a fracture. So at this point, would you guys agree that it's probably better idea to take maybe a further investigation like a CBCT or a three-dimensional image?
Yeah, sure.
Yes.
Well, definitely, Luca. I think getting a little bit more of that volumetric information, some other parameters to assess the situation.
Yeah.
For me, the idea to take a CBCT is also in order to extract the tooth and to place implant with planification. For me, implant in the anterior area always means implant placement through a guided implant position. So I will need for sure a CBCT in order to plan the guided implant position in the aesthetic area.
Okay, thank you, Martina. So we agreed to take a CBCT because we are probably thinking to give this guy an implant-supported restoration. Therefore, this could be an option, a good option. And what are the parameters you guys evaluate when we look at CBCT like this?
Well, I believe that first of all, we need to evaluate the buccal bone plate,
okay.
the dimension of the buccal bone plate, the dimension of the palatal plate, either this triangle in the apical area, and if it would be possible to encourage an immediate implant or other.
So you guys agree? I mean, buccal plate plays an important role. I mean, let me tell you that for me, buccal plate it plays a role as far as it's intact, but for the thickness, I'm not really concerned because we know there are some studies from Complutense showing that 87% of our patients in the aesthetic zone, they will have a buccal plate less than a millimeter. So I try to treat all the patients with that are going to receive an immediate implant placement in the aesthetic zone as they were in that 87%.
Sure.
So the thought I'm giving to this case is I am much more concerned about how much palatal bone I have related to the sagittal position of the tooth. So that is my main concern, if I can place the implant. And then do something to manage the remain bone or to the gap, let's say, between the implant and the buccal plate, which has to be intact, and then to manage maybe the soft tissue. So which are the steps you guys?
Completely agree with you. Also for me, what is really crucial on the vestibular aspect is to increase the soft tissue thickness. You know that I am a periodontist and I have a soft tissue bias in my treatment concept. So.
You're right. The buccal plate, as you said, most of the people in this front area of the maxilla, it will be very thin. So anyway, you're gonna have to increase the bone there, and you're gonna have to increase the soft tissue either, because anyway, you're gonna have some problems, static problems.
And also we have considered the prosthodontic solution. For example, the provisional restorations.
Yeah. Yeah, because we jump immediately, all of you, into the immediate implant placement, and which it's a good thing we basically agree on this, but of course there are other possibilities, such as not implant-supported restoration, maybe some type of a minimal invasive, more conservative type of approach with some adhesive type of restoration. Or maybe we can do like a socket grafting or a weight and then place a delayed implant. So I think we are on the same page that placing the implant is not going to affect the bone healing at the time of the extraction. So we basically go ahead and extract the tooth at this point. So the protocol that I think was ideal for this type of patient was to place the implant and then managing the void. How do you guys manage the void between the implant and the buccal plate, and how much distance do you like to have from the implant to the buccal plate?
Well, we have to put some low resorption bone substitute. So we would have to have at least 2 millimeters of this gap to fill it. But anyway, independent of the size of the gap, you have to fill it. And even with this bone graft that you fill it, you have to be concerned about the soft tissue either.
Exactly. So I would totally agree with what you just said, because no matter what we do, we still are going to have resorption. So in order to mimic the absence of the resorption, what we are going to do, we are going to increase that soft tissue thickness, so the resorption will happen no matter what, and we are going to mimic and try to say, okay, so which are our options? I think soft tissue grafting, Martina, you are the expert on this.
Yes, as I told you before, when I place implant in the anterior area, I always prefer to do a guided procedure, and I always open a flap. I do guided surgical implant placement along with open the flap, especially because when you're extracting this kind of tooth with a fracture, with a deep fracture, there is the risk to damage and to tear the interdental soft tissue during the extraction of the fractured tooth.
Okay.
So I prefer to open the flap, elevating split thickness, the vestibular papilla, and to see the bone crest and to be able to do a more gentle extraction of the tooth. Then I place with the guided procedure my implant. I feel the gap, but most cases I use transmucosal implant also in the aesthetic area, and in the suprabony component I want to have some bone, you know, the portion of the implant that should be osseointegrated should be at more or less 3.5 millimeters from the soft tissue margin of the adjacent teeth. And this portion should be osseointegrated and should be filled with bone also in the gap. But in the suprabony component, I always place a connective tissue graft in order to increase simultaneously also the soft tissue thickness during implant placement with a coronally advanced flap.
Okay, so thank you.
With immediate implant installation.
I perfectly agree with everything you said, except for the fact that you are opening a flap. Are you guys, how do you feel comfortable opening a flap in a case like
that
this?
will be coronally advanced.
I think Martina has a good point. There's several aspects that have been discussed here, and I totally agree with a number of different things. So obviously, managing both soft tissue and also the bone simultaneously to almost overcompensate to achieve the most dimensional, stable site for an optimal aesthetic outcome becomes very important at this stage. Now, whether you have a full access to evaluate these structures that you're starting with, I do first establish this with my cone beam CT. Is there a need in terms of the integrity of the buccal plate for me to better assess this clinically? In a case of a trauma, is there a potential fracture that could be compromised or further compromised during the extraction? So to minimize losing valuable tissue in certain options, I do like to
open
flap,
the flap.
and I'm not afraid of.
But
yeah.
you can probably check for the integrity of the buccal plate after the extraction without really opening the flap.
Yes, you can. But in certain situations, and depending if there's, for example, and not in this particular case, but a periapical lesion,
Yes.
do you want a little bit better access
Okay.
to compensate for these other factors that are going to be determined for successful outcome? So I'm not going polarizing myself with always flapless or always flapping. But in certain situations, I think there is a true advantage from having good access with flap. I don't know, I would like to hear other experts here in the panel.
I agree that most of the time I'm not a big fan to open a flap, you know. I usually don't open a flap, but I agree that in some situations you should do that, because there are some conditions that you cannot deal with without opening a flap. But it's not my daily practice, you know.
Yeah.
Usually I don't open a flap.
So just to summarize, I understand Martina to open the flap,
And
but
to see, because I want
but-
to see exactly.
Yeah, but she's very good with her hands, and she can do the partial thickness elevation and advancing the papilla, and you know, it can be a little bit more difficult. Sometimes I think if we check for the integrity of the buccal plate, and I agree with you, the extraction has to be as traumatic as possible. Today I use the tools that they remove. Like when you open a bottle of wine, so it's a kind of.
You are from north of Italy, so you know very well how to open a bottle of wine. We know.
Exactly. So at that point, if the integrity of the buccal plate is confirmed, then I don't like to open a flap. I like to place my implant, the bone substitute material like a xenograft, has low resorption rate, and then a connective tissue graft. As Martina said, the quality of the graft is it's most important thing. So soft tissue quality, so superficial connective tissue that we place underneath. This is a procedure that is much easier than a root coverage, because we are not trying to achieve root coverage, we are just increasing the thickness. So at that point, I don't do immediate provisionalization most of the time, but that's only because my prosthodontist is not in the office every day. So it's just a type of
It's just a technical,
technical
problem. It's not issue.
problem.
It's not.
But we like this protocol to put a Maryland bridge at this point that is bonded with no tooth preparation of the adjacent dentition, and has an oval pontic design that keeps pressure on my connective tissue and keeps the gingival architecture exactly like it is from the extraction, or before the extraction, I would say. So which type of restoration you guys use in these cases?
I totally agree with you. I'm in the same spot of you. I usually don't do immediate professionalization of immediate implants. I know that it can be done, but
and the literature is actually telling us that should be better.
I like this connective tissue covering it, you know, to get more keratinized tissue later. So this is something that I do. I agree with you.
Jay, are you more of an immediate provisionalization guy?
Yeah, if I can get the primary stability of the implant, I normally place the provisional the restorations at the time of the implant placement, because of the papilla levels. I think the papilla levels are the most advantage of the placement of the provisional prosthodontics.
It's something to consider, Luke, as well, is when you look at your provisional, is your smile line. Is it a high smile line? Are you concerned with, as the marginal tissue heals and stabilizes with, some collapse? Is there an advantage to either having some level of support to guide the soft tissue as it heals in that initial phase? So
what has this to do with the smile line? Sorry.
Yeah, in terms of if you go with, for example, what Jay was discussing, in a very stable implant placement, having that immediate provisional to guide the soft tissue healing.
Yeah.
Okay. Supporting that papilla, supporting that.
Yeah, but what I'm doing is an ovate pontic, so it's designed 2-3 millimeter inside the alveolus, so it's keeping a lot of pressure on that soft tissue. So for the time that it's now I don't have unfortunately the picture, but normally it heals like almost it was already designed. The gingival architecture never collapsed in this way. I would agree with you not to give like something removable or something that is not keeping a pressure and not keeping the gingival architecture ideal. So I think we agree on this case. We finalize the case, and this is definitive restoration. And here is 6 months post-op. And it's interesting, this case was done in 2010. So now it's 2018. And I had the opportunity to take a picture of him in last July. And I look immediately at the thickness that I had around the implant crown. And I actually have higher thicker, so the thicker is increasing. And this is amazing because, when we look at the literature, the ITI consensus 2009, the ITI consensus 2014, the updated one, is showing us that basically 1,107 articles telling immediate implants are at high risk for developing peri-implant mucosal recession. And I totally agree with this. If you think of immediate implant placement such as a procedure where you extract the tooth and you place the implant, period. But that's not what we discuss and what we show today. Okay, you guys are on the same page.
Yeah, I agree with you, but we have to think about that. Sometimes clinicians with the immediate implants, they just put the implant and the bone. They don't put the connective tissue.
Exactly.
And you're going to have the resorption of that buccal plate. It's 0.5 millimeter or 1 millimeter, and this is going to keep the tissue down, a static problem.
I think you
so
made
the connective tissue is important.
I think you made the key point. Because some years ago, when I was in residency, I was taught bone is everything. But now, thank you to people like Martina and Kelly, we know that I rather have a 2-3 millimeters of tissue more than the bone. I like to have the bone as well. Okay. Sure. Because there are some people maybe they are more concerned about it.
I like to have the bone too, but only in that portion of the implant that should stay inside the bone.
Okay.
In the part that is the distance between the osseointegrated portion of the implant and the gingival margin of the adjacent teeth is like around teeth. You in the suprabonic component, you don't have bone in your central incisor. So in that portion, you need soft tissue, and you need a soft tissue thickness of 2 millimeters in order to prevent.
So let's move to another case, another female, 34 years old. She had a bike accident, unfortunately, and this is a little bit more challenging because before we had a square tooth shape, already a thick phenotype. Now instead we have a tooth which is number 21 with the bed fracture, and we have already a gingival recession, as you can see on number 21. So again, what are your concerns here? Are you worried about this ongoing recession? This is definitely a thin phenotype type of patient, high smile line.
For me, this is a situation that we really need the soft tissue, and maybe
to open a flap.
To open a flap. Not really, but
you can say it.
No, I can say that you can open a flap, but you can also don't open a flap and you just cover the alveolus with the soft tissue, just like you did in the first case. Not with the immediate provisionalization because of this recession. So you need a flap, or open a flap to increase that, or cover the alveolus. That's my idea.
Jay, would you go with immediate provisionalization here?
Yeah, but I think this case is very challenging cases, so it's better to go to more conservative. We can consider the prosthodontic process than the implant placement maybe. But in case for the implant placement, I totally agree with the Cleverson's opinion. We can approach more soft tissue than the bone volume.
So, Christina, would you agree?
I try to do the provisionalization because we have a very good amount of bone
So with
The
the,
base?
with the immediate implant.
Yes, with immediate implant, if the extraction will be okay, I will open the flap. I agree totally with you because we want to, here we have to be in control with the soft tissue. And I will go for the tuber to have a thick soft tissue to cover
graft.
the recession and to have a good thickness of soft tissue because
Other thing that, sorry. Other thing we should consider is the possibility of an early implant placement, not an immediate implant placement, because with an early implant placement, you're going to have a thicker tissue
Yeah.
This is
after
something
a few weeks.
back at Harvard, I always have hard time to discuss.
Yeah. I know
I
that.
really don't like the delay, the delayed place, the early placement.
Yeah, at Buzzard has a lot of papers on it showing the stability of the tissue, and so the reconstruction of the bone later, with a thicker tissue. But it's
The thing is that we have a socket
option.
that has been just where the tooth has just been removed. I think the potential, the regenerative potential of the socket, is much higher than a defect that it's in his healing process. So you are going to alter the phase of the healing process because after 6-8 weeks, the site is not healed completely. The proliferative phase, I mean, it's over, but it's not mature, and you are re-enter the area with the soft tissue is not mature again, and you are you have to proceed with a guided bone regeneration, which may be not easy for everybody, using maybe some non-resorbable type of membrane. I don't know. I mean, for me,
And
this.
also, yes, the reason to wait some weeks is just to wait for the soft tissue healing in this period. But in that case, you already know that you have to add some tissue thickness. So there is no need for me to wait this small amount of healing of soft tissue.
I mean,
This is-
for me, this case is a pretty straightforward case because, as I was telling you before, no matter if the patient has a thin or thick biotype, phenotype, we should say, I treat the patient at the same exact way if the buccal plate is intact. I do not open a flap in this case. I check for the integrity of the buccal plate, so I have a type of defect that can be contained. So at that point, I place the implant in the three-dimensional position, the bone substitute material like a xenograft with slow resorption rate, and then the key is the connective tissue. Connective tissue is something that, in this case in particular, it cannot be avoided. And I think immediate professionalization may be not the best solution for this case, even if you had enough torque, because you have to bring down a little bit that tissue. So you want to use a connective tissue that will be folded over the socket like as a socket shield, and then stabilize on the palate as well. And after we have done this, we push with the three-dimensional ovate pontic as a Maryland bridge to maintain the gingival architecture. Are we on the same page? Or
Yep.
Martina would have no doubt about that. But again, in my hand is a more difficult surgery.
For sure.
For you, not. For you, it's easy.
For me, no.
Comes natural.
And yes, it comes
Listen,
natural.
you're a natural.
And then I prefer to really see the buccal bone and to really decide where to place some bone substitute and where to.
That's
fix
right, because the
my
risk in this type
connective tissue.
of
And
procedure.
And I open a flap, but then I release my flap. So I cornerally advance the flap a little bit in order to reduce the risk of flap shrinkage due to the opening of the flap, for sure. And if I need to advance, like in this case a little bit because there was a recession, I have to open my flap.
Yeah.
But I think it's not a critical point. This is the point which is, you used to do it open,
Yeah.
and you're sure that you
I'm
will be...
comfortable with this
Okay.
kind of procedure, yes, but this
the
work,
other people to do the tunneling
Yes.
and also have a good result. Here, the result connected with the right position of implant, it is connected with the gap closure, and for sure it is connected the quality and the quantity
Of the connective tissue.
connective tissue.
For sure.
And this is influence on the treatment not the technique,
Completely
but
agree.
because the technique we are advocating for is very good, but it's very sensitive. It's not working in every hands. And tunneling, I think it will be a little bit easier. And in this case, when the buccal bone is preserved, I think the result is very nice.
Yes, no, I perfectly agree with you. This is simply different
No,
philosophy of
exactly,
working, but
exactly.
the concept
Concept is the
behind
same.
Is to
our
achieve
treatment
the same
approach
goal.
is to place
That's
bone
interesting
and
because
soft tissue.
we have always different options.
Background, and we have different background, but at the end we
But-
arrive at the same.
But the
There are
goal,
different ways
the
to
goal,
get the same
outcome.
the goal should be the same. So it's 5 years, we don't see any recession of peri-implant mucosa, and the patient is still happy and coming to the office. So that's good. Now, just to be a little bit, to show a little bit different case, because as Martina liked to open flaps, so I'm going to show you in my hands when I like to do this. And I don't know if you agree with me, but this is a 30-year-old female, no nose allergies, as well, no contraindication to treatment. And she had a chief complaint that her lower incisor was sore. She said, I had an endo treatment, which didn't go well. And I'm still in pain of my lower incisor, so this is the situation. At this point, I had an endo consult, another endo consult, and a colleague told me, there is no way we can do anything for these two, so you have to remove. So you guys are expert clinicians, so you have deal with the upper incisor, of course, but my real challenge are the lower,
Yes.
because we are talking about extremely thin type of phenotype, not only
implants.
soft tissue, but bone as well.
No implants here.
No
For me,
implants here.
it's
So
really
this is interesting because treatment options here are, of course, first discussion. So which is the best treatment sequence? How do we manage the very thin periodontal biotype? And which could be the best provisional fixed type of restoration for the patient? Because as you said, implant may be not first option.
No, not first option. I did socket preservation, soft tissue grafting, and
Okay.
Maryland in the end. I think it's the chewing processes doesn't disturb if we have a Maryland here, but for implantation, this is very challenging case, and we don't know how it behave himself in the future because the bone is very thin, and we are only hope if we have an implant here, this is the soft tissue. This will be soft tissue if we use that, it will be stable and we don't lose it with the time. So I will go
for prosthetic solution, but managing the hard and soft tissue to maintain the volume,
yes,
of course.
yes, that's
That's an option. I mean, you guys are on the same page. I honestly don't like that this option a lot, because we are in the lower area where there is a potential for a lot of plaque accumulation. I see with Maryland in the lower anterior, there is always a problem. The patient cannot use the
but we see a lot
Interdental
of
soft tissue brusher.
interdental soft tissue brush,
But we have a lot of patients with the retainers after orthodontic treatments, and by brushing the teeth.
Yeah,
I
but
think,
in Maryland, just the extension is it's higher. So
it's my opinion. Maybe
No,
it's a very young patient, as I see
38,
by.
yeah.
Yes, and in the future, when she or he lost more teeth, maybe we return to the implants with the other corner. But now I suggest two types
you
of
feel
treatment.
more. It's
Yes.
an
It's
optimal treatment and ideal treatment. So there's
Yes.
nothing wrong with it. It's just one of the options. Hector, what would you go for?
Well, here in this situation, I agree with the challenges that are presented. So taking a step back and really developing the site, making sure that you overcompensate to have both sufficient bone and soft tissue. To them, at this stage approach, consider implant placement, I think is a viable alternative to discuss with the patients to avoid what you were saying. And when you're thinking about maintenance and longevity of this situation where a patient is going to be comfortable with that, I think this is where, okay, well, maybe you want to consider developing the site, addressing some of these deficiencies, some of these challenges.
Maybe
Exactly, this anatomical.
This could be an option. Actually, you would be impressed because I didn't go for either one or the other. So I took a CBCT, of course. This was done after the extraction because it was part of the protocol of a study. But anyway, this is definitely a class 4, what Joseph can describe as a class 4, where the sagittal root position occupies the entire space. So I don't have enough space to place my implant far away from the lingual and buccal plate. So I know that my implant is going to be in contact, perhaps, with the buccal plate, which is not even completely, the integrity of the buccal plate is not complete. So we have some deficiency, I would say, okay? So this is a case where I am definitely going to open the flap. And this is exactly what I do, but I still place the implant because I feel like the implant is not really interfering in my blood clot stabilization, my endothelial stem cell differentiation. The bone is going to grow anyway as far as I have stability. So what I'm doing is placing the implant, the bone graft to hyper-augment the area. I know somehow it's going to resorb, but that's why I want to hyper-augment. And then using a membrane, a barrier membrane, maybe a collagen membrane, of course, not like that.
PTF.
Yeah, that it doesn't need to be removed, so a collagen membrane that will maintain the stability. And then, Jay, I'm doing immediate professionalization here as well. You know, I mean, because
This is for us.
exactly, I learned from you guys, and that's what I did.
At the end, okay.
At the end, I said, okay, I'm opening the flap, I'm doing the immediate professionalization.
And no soft tissue?
And not some tissue.
That's a good point. So this is not the time for me to do the soft tissue because it's too much things. If I'm doing the bone graft with the membrane, I don't think the soft tissue should be done at this point. What do you guys feel? It can be done maybe at the same time? I mean, I felt it was already enough things.
If you open the flap, maybe there is some idea to put also soft tissue here.
Yeah, but you see,
I agree with you. It's very
I have
challenging.
bone to grow on the facial aspect of this implant, so I want my membrane to adapt nicely in that area. So the soft tissue is going to be over the membrane.
But in a resorbable membrane, I would not be that concerned
Yeah.
with adding the soft.
So I felt the soft tissue should be postponed later, and that's exactly what I did because if you take, I would say 95% of our colleagues, they will feel comfortable to put a crown here, but I won't because I know, as we discussed, that we need more thickness. So what I'm doing here is just create a small pouch, what Martina doesn't like to do, and push a little bit. It's like a 10-minute procedure, I guarantee, Martina. So no incision, no suture, basically, suture, but just push a little bit of slice of connective tissue, and we have this thickness. And that's what makes our implant looks exactly like a natural dentition at 1 year, at 3 years, and at 4 years. And I think this is a pretty good result because we mimic the presence of the tooth, basically, and we have a absolute matching of the interface, soft tissue interface between teeth and implant, even though because of the graft, it's still blinching a little bit, the color, it's a little bit, but I think so.
Perfect.
Very nice.
Very
Beautiful
nice,
case.
and I think this is very nice result to show how the good team is working. It works in very good hands, but I'm not sure that in every clinic, every hands it works like.
Well,
like
Martina do it every day.
we don't talk about Martina.
But this was the
No,
day that your prosthodontist was
the-
in the office.
Exactly. So guys, I think we could go ahead all day if you want, but it's time to go. So bye everybody, and see you next time. Thank you guys.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.